You. Hi, I'm Dr. Kanishka. I'm a consultant at Metro Center for Respiratory Diseases, Noida. And we have gathered here for the ALFA workshop, which is the Advances in the Lung Function Assessment Back to School, organized by Pulmonary Allergy and Critical Care and Sleep uh, uh, body, which is the PAX India. And I thank CIPLA for being the education partner. So we have seen till now that we have discussed the physiology of the lung and the lung volumes by Dr. Deepak Talwar sir and Dr. Lavleen Mangla respectively. And now I'm here to talk about the advanced lung function, which is the diffusion capacity of lungs for carbon monoxide. So we'll be going step by step and we'll be talking about its principle and how do we interpret all these tests. So when we inhale air, the mixture of gases, it goes from our nasal cavity into the trachea and then further goes to the alveolar space. And there after that, it crosses a few barriers, which includes the alveolar basement membrane, the interstitial space, the capillary basement membrane, the capillary endothelium, and then it crosses the red blood cells and then combines with hemoglobin. So all this process which happens inside the body, we need to calculate it just by giving a 0.3% of carbon monoxide along with the mixture of gases along with which we inhale and also the 10% of helium. So when all this happens along with the gas, which is the carbon monoxide, it determines the volume of gas which will diffuse through the membrane each minute for a partial pressure difference of 1 millimeter of mercury. And DLCO thus is a measurement of the ability of the lungs to transfer the gas from inhaled air to the red blood cells in the pulmonary capillaries. So as we discussed in the previous slide, that it has a few barriers, and all these barriers are the determinants of the diffusing capacity. So what are these barriers? I will repeat once again. This is the area of alveolar capillary membrane, the thickness of the membrane, the driving pressure created by oxygen across the gas in the alveolus to the blood in the venous capillaries, and the passage through the RBC membrane, and finally the combination with the hemoglobin. All these barriers are connected in series, and when they're connected in series, the resistance will be added as their reciprocals. So the equation which you can see inside in the right hand side corner is the equation for the DLCO, in which the DM is determines the properties of diffusion across the alveolar capillary interface. The theta is uptake of carbon monoxide by hemoglobin, which depends upon the reaction rate, and QC is the pulmonary capillary blood volume. So all these factors are important in determining the diffusion capacity. And sometimes it is also called as the transfer capacity in some European countries, and DLCO can be also called as the transfer capacity of the lungs. So what are the factors which influence the diffusion capacity? So as we discussed in the previous slides also, that there are structural factors that includes the lung volume, the thickness and the area of the alveolar capillary membrane, the volume of hemoglobin in the capillaries supplying the ventilated alveoli, and there are functional factors which includes the absolute levels of ventilation and ventilation perfusion ratio, the composition of the alveolar gas which we inhale, diffusion characteristics of the membrane, how the membrane structure is, the concentration and binding properties of the hemoglobin in the alveolar capillaries, and carbon monoxide and oxygen tension in the alveolar capillaries are also very important to look for. It is performed for various uh, various conditions, which includes the screening. The screening includes early ILD patients, early emphysema patients, pulmonary vascular disease patient, occupational lung disease patient, and the patients with drug-induced lung diseases. And when the patient comes to you with the complaints of shortness of breath, it helps you to get a differential diagnosis or to reach a diagnosis, because it is a sensitive indicator of lung being a sensitive indicator to find out the cause of the shortness of breath, which can be obstructive, restrictive, or it can be due to the vascular disease. It helps in assessment of the severity of the diseases like COPD or interstitial lung diseases. And when you have diagnosed these diseases and the patient comes to you for the follow-up, so at that moment you can do the DLCO test to understand how is the disease progressing with all the medications which you are giving to the patient. Which are the common conditions of the of which you see in the patient where you think that the DLCO is helpful. The three of them which I have written is the DLCO is a specific but insensitive predictor of abnormal gas exchange during exercise. But a low DLCO less than 50% predicted can predict hypoxemia with exercise. But normal DLCO does not rule out oxygen desaturation with exercise. So ABG analysis is also used for the long-term oxygen therapy. And DLCO can be decreased in cases like HIV, which signifies that the patient could have developed opportunistic infections or pneumonia. A low DLCO with a normal chest radiograph, which you see, can be seen in early ILD patients or patient with pulmonary hypertension. So what are the different methods which we use to calculate the DLCO? There are three methods, which the first one is single breath hold technique, second one is the rebreathing technique, and the third one is single breath intra breath technique. Single breath hold technique is the most common and clinically used worldwide. The advantages of single breath hold technique is it's very simple, fast, and it's very much standardized and easy to calculate. So all the most of the centers in India are using the single breath hold technique. The disadvantage is that it is sensitive to VQ mismatching, and the it's I already said that it's mostly used clinically for the patients. There is second technique is the rebreathing technique. The advantage is that it is less affected by the changes in the alveolar volume and less sensitive to the VQ abnormalities. But the disadvantage is it is complicated and still it is not standardized. Of course, it can be used clinically, but not standardized. Now, the third one is single breath intra breath technique, in which there is no requirement for a breath hold, because in the single breath hold technique we will be requiring the patient to hold the breath for at least 10 to 12 seconds, but few patients cannot hold the breath for such a long time. Then single breath intra breath technique will be helpful for those patients. Of course, it has a complex calculation and still not very much standardized, but can be used in patients who are not able to hold the breath. At our center, Metro Center for Respiratory Diseases, we are using single breath hold technique and both single breath intra breath technique. So first I'll be talking about the single breath test maneuver for the DLCO. Here you have to ask the patient to have to go for a quick inhalation to the vital capacity. I repeat, the patient needs to inhale the gases quickly, not forcefully, and then you have to tell the patient to hold the breath for at least 10 seconds, and then quick exhalation with the collection of expired gas. Quick, the expired gas is done, and after that is done, after the patient exhales around 700 to 1 liter of volume, and then we can take a sample after that, which is around 500 ml, and then we can analyze the DLCO. So the gas mixture is the contains carbon monoxide 0.3%, helium is 10%, and oxygen is 18 to 25%, and the rest of the gas is being the nitrogen. So the breath hold time, that is called the Jones breath hold time, is a 30% of the inspiratory capacity taken, and then the end point is the midpoint of the sample collection time. So this is the Jones breath hold time. It must be around 10 plus minus 2 seconds to consider the test being perfect. But what can go wrong when you tell the patient to the DLCO test in a breath hold technique? The potential problems include the transient overshoot. I told earlier that you have to tell the patient to be very much quick but not forceful, because the patient can go and hit the transient overshoot while inhaling the gases forcefully. And there can be situation when the patient inhales or exhales stepwise, or the inhalation is very much slow, the breath hold is not appropriate, and when the patient exhales, the possible exhalation is very much quicker or the larger than the inhale volume. So these kind of uh, errors can be seen when we tell the patient to perform a DLCO. So we need to have a good technician and expert sitting with you to guide the patient to how to do the procedure, which will be seen tomorrow at our center for Metro Center for Respiratory Diseases. I was talking about the other technique. What happens to such patients when the patient is not able to hold the breath for at least 10 until 12 seconds? Also can be seen in various condition restrictive lung diseases. Then there is an alternate approach, which is the intra-breath technique, which was proposed by Morton and Wilson, in which the after exhaling to the residual volume, subjects inhale the DLCO gas mixture to the total lung capacity, and after breath holding for approximately 1 or 2 seconds, which is very much less as we compare to the some single breath hold technique, which was 10 seconds. The subjects exhale slowly at a constant rate of 0.3 to 0.6 liter per second, and the gas concentrations measured between the 20% and 80% of the exhale volume are used to calculate the DLCO. So is the intra-breath technique similar to what we have observed in the single breath hold technique? There is a study in the Japan which was published in 2005, where they compared the 32 normal subjects and 88 patients with obstructive impairment and 39 patients with restrictive impairment. There were few patients who could not do the single breath hold technique due to the restrictive or obstructive defects, but DLCO intra-breath was done in all of them, and there was excellent correlation between the DLCO intra-breath and DLCO single breath hold in normal subjects, the obstructive impairment group and the restrictive impairment group both. So the gas which we use is the carbon monoxide, because the measurement of oxygen diffusion capacity requires the alveolar PO2, the PO2 in the pulmonary capillary blood, and the rate of oxygen uptake by the blood. So when we use carbon monoxide, the rate of oxygen or hemoglobin, which combines with the carbon monoxide, as discussed in the first lecture also, that carbon monoxide gets loaded on the hemoglobin very quickly, and hemoglobin combines with the carbon monoxide so rapidly that its pressure never builds up in the pulmonary capillary blood, and there is a low solubility in the pulmonary membrane, so there is no back pressure of the gas, and due to its easily solubility we use carbon monoxide. What are the precautions which needs to be taken care when we tell the patients to do DLCO? Then no more than 5 tests must be performed in the same subject. At least 4 minutes should be allowed between the two tests. Subjects must be asked to refrain from smoking or other source of carbon monoxide exposure on that day of the test, because when the patient has been smoking on the day of the procedure, then there will be a defect in the DLCO measurements, and the DLCO measurements can be low at that in that patient. And therefore, patients having obstructive lung disease, sufficient time, which is up to 12 seconds, should be given for the exhalation to the residual volume. Inhalation of the test gas should be maximal, and during the breath hold, both Valsalva and Mueller maneuvers can affect the DLCO calculation. So we need to tell the patient not to do that. For the acceptability of the test, inspired volume should be more than 85% of the largest vital capacity and obtained within first 4 seconds. Stable breath hold for at least 10 plus minus 2 seconds. That means breath hold time should be around 8 to 12 seconds. There shouldn't be any evidence of leaks or Valsalva middle maneuver during the breath holds, and two such acceptable tests with intra-test interval of 4 minutes should be there. And talking about the repeatability criteria, the two acceptable test reports should be within 2 milliliter of carbon monoxide per minute per millimeter of mercury, or within the 10% of the highest value. But when we do the test, there must be some adjustments done according to the patient's age, gender, height, race, hemoglobin, lung volume, carbon monoxide hemoglobin combination, and the PiO2, which can be different at different altitudes. It varies with the exercise and the body position. The DLCO will be different in supine, and the DLCO will be different in sitting position. But mostly we do it in sitting position, so that's not a problem. But when the DLCO is done at plains, and when DLCO will be done at the places with high altitude, both will be varying, getting the varying results in the same patient. So we need to adjust all the values according to the altitude also. And when the patient has anemia, then also the combination of carbon monoxide with the hemoglobin will be different, so we will getting different results. So we have to look for the anemia in the patients, and if there is anemia, then we have to do the adjustment before doing the or getting the printed result for the DLCO. So DLCO is KCO multiplied by alveolar volume. KCO is the rate of uptake by the blood, and VA is the alveolar volume that we'll be seeing in the further slides. So adjustment of DLCO for hemoglobin must be done, and DLCO, I repeat, is directly proportional to hemoglobin, because there will be hemoglobin, more there will be combination with the carbon monoxide. So if hemoglobin is decreased, then measured DLCO is also decreased or reduced, and if hemoglobin is increased, the measured DLCO is also increased. So adjustment calculation is written on the slides, which you can refer further if you want to remember or use it in the clinical practice. Now, DLCO and carbon monoxide hemoglobin adjustment is also required, because carbon monoxide hemoglobin can affect the measured uptake of carbon monoxide which you give to that patient at the time of the test. And 1% increase in carboxy hemoglobin reduces the measured DLCO by 0.8 to 1% at that moment. So that's why we tell the patient who smokes to refrain from smoking on that particular day, because that will be, when you do the DLCO test on that patient on that particular day who has smoked, the DLCO will be reduced. But if the patient has smoked and he has come for the test, you can't say that we won't be doing the test. So you need to do the adjustment. Like adjustment for carboxy hemoglobin is usually not required, but may be done when the carboxy hemoglobin is elevated, which is seen in the smokers. Now we generate the report. We have done the test and we generate the report, and the predicted and absolute value and percentage predicted of the following measurement needs to be reported at the time of reporting of the DLCO, which includes the unadjusted measured DLCO, DLCO by VA, which is the KCO, and there is if there is any adjustment required for the hemoglobin or the carboxy hemoglobin, or the test is when the test is done at higher altitude, and average alveolar volume. Now we'll go to the interpretation part. First, we will have to see at look at the DLCO, which is reduced by either a decrease in VA or KCO, because DLCO is equal to the product of VA and KCO. So it is directly proportional to the alveolar volume and the KCO. So we need to look for the both components, and then we have to see and look for the DLCO, which is in the normal range, or it is decreased, or maybe it can be increased too at some times. Now we look at the VA. The normal value of VA, the normal value of the VA is almost 85 to 90% of VA by TLC in all the adults in which we do the test. So if the VA is less than 85 to 90% of the TLC, then you can know that the VA is less. If it is around that 85 to 90% of the TLC, then you know that the VA is in the normal range. Now, after you have seen the VA, you go and see for the KCO. The DLCO by VA is the KCO, which can be reduced in anemia, ILD, or pulmonary vascular diseases. Now, severity classification of the DLCO. DLCO can be uh, seen by Z scoring also. Z score represents the normal distribution in healthy individual, taking into account the reference equation parameters, that is the age, sex, and height. Now the normal range is Z score range is minus 1.645 to positive value of 1.645, which is 76 to 140% of the predicted value according to the European Respiratory Journal, which was published in 2022. But in some of the machines, the Z score is not there. So if you get the DLCO values, then you can classify your DLCO abnormality with abnormally high if the DLCO is more than 140%, normal is 76 to 140% of the predicted value, mild impairment is 61 to 75% of the predicted value, moderate impairment is 41 to 60, and if the patient is having less than 40% of the DLCO, then the patient is classified as having a severe impairment. Now the case DLCO by VA is KCO. It determines whether the currently available alveolar spaces are functioning normally or not. So when we see the patients with the low DLCO with a normal or high KCO, so KCO indicates that the remaining lung tissue is functioning normally, example, pneumonectomy. So if the part of the lobe is removed, the DLCO will be low, but the remaining part which is there is functioning normally, so the KCO will be high. So elevated DLCO by VA, that is the KCO is because there is increased blood flow in the remaining lungs. DLCO can be falsely reduced in patients with severe COPD or ILD when the inspired carbon monoxide does not completely reach the functioning alveolar capillary units. This is the interpretation chart. So when we'll be interpreting, I have 5 cases with me and I will be interpreting all of them. And this is the flowchart which we are going to refer again and again. And so I will skip the slide, and because we have to come to this slide again and again. So what happens when you see the isolated reduced diffusion capacity? Isolated reduced diffusion capacity can be seen in patients with pulmonary hypertension, in congestive cardiac failure, patients with anemia, early emphysema, morbid obesity, cirrhosis of liver, diabetic lungs, kyphosis, and eventration of diaphragm. There was a study which was done in 2007 in which they saw there was a 0.5% of the PFTs which showed isolated reduced diffusion capacity. And in those patients, 0.5 patients, 48% had emphysema on HRCT scans. And out of those patients, 85% had the concomitant ILDs, 22% has ILD or DPLD, 7% had pulmonary vascular disease, and 19% had normal CT and echo in this study. So these are the some conditions where you can see how the VA and KCO and DLCO works. So like in complete lung expansion or the neuromuscular weakness, you can see the VA is reduced significantly and the DLCO will be reduced and the KCO will be normal or high, as we discussed in one of the examples that due to the increased blood flow, KCO will be high in the patients, in some patients. Now the second example is the pneumonectomy, in which you can see the DLCO and VA are reduced, but KCO is high. Diffuse loss of alveolar units like in interstitial lung disease, all three of them will be low, but the DLCO will be significantly low, followed by the VA and then KCO. In emphysema, everything will be reduced, or the VA can be normal in some situations. And pulmonary vascular disease, the VA will be normal, DLCO and the KCO will be reduced. In heart failure patient, congestive heart failure with high pulmonary blood volume, the VA will be normal, but the KCO and DLCO will be increased. Alveolar hemorrhage, the KCO and DLCO will be increased significantly, and there will be mild decrease in the VA. Now we are about to discuss the 5 cases which I told. So first of all, when you get a test report like this, you have to see that this is done by which method. Like this is done by single breath hold technique. So you have to look for the breath hold time. Has the patient hold the breath for the sufficient time or not. So we can see the breath hold time is 10.47 seconds, and this is sufficient for us to make this test acceptable. Now the DLCO is 75%. DLCO 75% is comes into the category. Now I'll tell you to visit this the diffusion abnormality. So that comes in mild impairment, 61 to 75%. Now next we see the VA. VA is 61%, and the TLC here you can see is 81%. So it is not 85 to 90% of the TLC. So that means VA is reduced. Now here you can see that if we go to the chart, now DLCO is reduced. Now we move on to the VA part. Now VA is also low, right? Then now we will be seeing the KCO. Let's see the KCO. KCO is 126%, which is high. Now we move on to the graph and then see. So the DLCO was low. Then we look the VA. The VA was low. Now we look the KCO, and the KCO is high. So the patient can have pneumonectomy. The patient didn't give any history of pneumonectomy. The CT was normal, but the failure to take deep breath was also not there because breath holding time was normal. And the third option is the neuromuscular disease. Yes, the patient had kyphus scoliosis, and you were seeing the PFT report of the DLCO diffusion report of the patient with the kyphus scoliosis. It's very easy to interpret. Now, moving on to the next case. Now we'll see the DLCO, which is 62%. It is reduced. Now we look at the VA, is 66%. The TLC is 94. So that means the VA is also reduced. Now we look at the KCO. KCO is normal, 96%. So what it can be? If we move on to the chart, you can see the DLCO is less, the VA is low, the KCO, if you look at the KCO is normal. So this is the patient of emphysema COPD patient. As discussed by Dr. Naveen also, here you can see, if you look at this graph, you can see the golf handle appearance, and that is seen in emphysema. If we look at the FEV1 by FVC, it is 61%. So all of this can correlate. If you have to make a diagnosis, you have to correlate everything: the spirometry, the lung volumes, and the diffusion capacity. Now moving on to the third case. Third case, DLCO is 103, which is on the higher side, not very high, but yeah, on the higher side. Now, when we see that when the DLCO is on the higher side, what options do we have? The options is increased blood flow, left to right shunt, asthma or obesity, and erythrocytes or alveolar hemorrhage. So is it now we have a certain differential diagnosis. So if we look at the FVC, there is obstruction, and there is a reversibility of 24% with a high DLCO. So can it be asthma? Of course, it is an patient. It is a patient with having an asthma disease, and we had seen just the DLC report of the asthma patient. Now moving on further, we can see the breath hold time is normal in the case 4. The DLCO is 42%. That means it is reduced. Now we will look at the VA, which is 52. If we compare it with the TLC, which is 68, that is reduced. And the KCO is 83%, which is normal. Now, if we put all the values in the test, DLC was reduced, VA was low, KCO was normal. So if this is the patient of interstitial lung disease that falls into this category. So we have seen one asthma patient, one COPD patient, one interstitial lung disease patient. And to confirm that, you can see the FEV1 FVC is also 107%, but there is evidence of restriction which is seen in the FVC. Now moving on to the fifth case. Here you can see DLCO. I had already told in the first slide that DLCO can be also called as a transfer factor. So DLCO, which is reduced, and now if you look at the VA, VA is normal. and if we compared with the TLC, VA is normal. So, but and if we compare the FEV1 by FVC, that is also normal. So where it stands and goes into the charts, DLC is low, VA is normal. So this is the patient with pulmonary artery hypertension, which came to our hospital, and we did this test because there is no evidence of restriction, so ILD is not there. So you have to look for everything when you perform a complete lung function analysis, the spirometry, the lung volumes, and the DLCO. So if you look at this DLCO, it is isolatedly reduced. So it is, this is a patient of pulmonary hypertension. So I have some few cases which I checked to compare that intra-breath real-time DLCO is similar to the diffusion with the single breath hold technique or not. So you can see in this patient, the DLCO with the intra-breath technique is 93%, and the DLCO in this patient with single breath hold, the same patient with single breath technique, is 92%. The second case also, you can see this DLCO is 97% with the intra-breath technique, and the DLCO is 97% in the single breath hold technique too. So tomorrow we'll be talking in detail. I'll be here to solve all the queries. We'll be seeing all the patients doing the test, and then you can have yourself make expert to see all the cases and how to do it, and so solve all the PFTs to get a diagnosis. So I'm pretty much sure that tomorrow will be an exciting day, and waiting for all of you to be there. Thank you so much.